What is the potential limitations of current ASD closure devices?
There are many ASD devices available to close ASDs. Most of these devices are what we call self-centering device. So you need a waist, and then beyond the waist you need a large left atrial disc and a right atrial disc. So for large ASDs with small atrial septum, these devices cannot be used safely. So that's number one. Number two, in smaller children where a lot of the ASDs present, also you cannot close these ASDs. So the major limitation is the size of the device inside the heart. So for a medium to large size ASD, you need a large device, and that large device may impinge on neighboring structures within the heart. So that's a problem with the available devices right now.
And please tell us your tips for improving success rate in very large ASDs.
Large ASDs, they pose a great technical challenge for the operator trying to align the left atrial disc parallel to the septum. So there are different techniques. Number one, the older techniques where you can deploy part of the left atrial disc in the left upper pulmonary vein or the right upper pulmonary vein, and then continue deploying the waist and then the right atrial disc. By doing that, because you are deploying the disc in the veins, which are very posterior, it makes the device align parallel to the septum. Another technique is an older technique that we developed actually. It's called the dilator assisted technique. So you insert from the other femoral vein a long dilator, you deploy the left atrial disc, and with this dilator you hold the disc in the left atrium while the assistant is deploying the remainder of the device. So this is another technique. And a third technique, which is called the balloon assisted technique. You have a balloon through the defect from the other vein, and then you deploy the disc and leave the balloon inflated, and that will prop the left atrial disc in the left atrium, while again you deploy the waist and the right atrial disc. Once they are deployed in their respective positions, you can deflate the balloon slowly and remove it. So these are the two or the few techniques. One technique that I did not mention is use of a special sheath. It's called the Hausdorff sheath. This sheath has certain curves at the end, so that when you deploy the device, the disc, because of the orientation of the tip of the sheath, it makes the disc parallel to the atrial septum. So these are the various techniques: the deployment in the pulmonary veins, use a dilator, use a balloon, or use the specially designed sheath, the Hausdorff sheath, to keep the left atrial disc. Because the key in all of the large ASDs that the left atrial disc has tendency to prop down to the right atrium when you deploy it. So you want something to keep this left atrial disc in the left atrium without propping down to the right atrium. And these maneuvers help in more than 95% of the time.
Would you tell us about the current criteria for using ASD closure device instead of open heart surgery?
That's a great question because probably you have heard recently now ASD devices in the US are coming under assault by the FDA. The FDA is calling a panel meeting on May 24th, so just about 3.5 weeks from now, to discuss continued availability of devices for ASDs in the US or not. And the major reason they are talking about the erosions, fractures of the frame, as well as embolization and thrombus formation. Certainly these are valid concerns by the FDA. However, these complications, if you would compare it to the traditional method, which is open heart surgery, are still much less than the complications encountered by open heart surgery. So at least nowadays, if in Chicago I want to take a patient with ASD to close, all these patients, they have to meet criteria, whether they require a closure or not, whether it's by device or by surgery. So they have to have enlargement in the right heart chambers by echocardiography. Once they have enlargement, then that's a class 1 indication according to the American College of Cardiology, American Heart Association guidelines. It's a class 1 indication. There are other indications when to close even a smaller hole, sometimes in a patient who has paradoxical embolism and a stroke because of a small ASD. Then those patients, you can also take them to the cath lab to close their ASD by a device, or even some people they use surgery. So currently the major issue that we are going to face over the next few weeks is discussions with the FDA about the whole issue of device erosion. Device erosion is very rare, about 2 per 1,000 cases, but the problem with device erosion, it is not predictable. Some cases happen acutely, some after a week, some after a year, some 2 years, some all the way up to about 6-7 years. That's the concern that, quite frankly, the FDA as well as us physicians, we have about devices. So to overcome all of this, we need to come up with new device designs, bioabsorbable technology, so that you don't have to worry at all about long-term sequelae from device erosion or embolization or fracture of the frame rate. So if companies are listening to this interview, I want to encourage all the industry to work very hardly in developing bioabsorbable technology, bioabsorbable devices, so that 3-6 months, nothing left in the heart, and the patient is safe and no sequelae at all.
Thank you for your talk.
Thank you very much.